this morning, my line over and over again is my son knew more math in the 8th grade than I know now. And so we, as clinicians, we rely heavily on you guys to both listen to us and let us know when we don't make any sense. So the talks this afternoon are again going to be spectacular. I want to first introduce Dr. Bazemore, and he's going to approach a topic that I think in the decade that we've been having these conferences, I bet we've never spoken about this. So again, I do intensive care for a living. A lot of us like the high data, the high adrenaline thing, but moving AI and ML into the front lines is just a topic that we've not heard yet. Dr. Bazemore.
And thanks to Mark Sindak for the kind invitation, Ryan, for the setup. I feel really honored to be here. And as I confessed to Dr. Fackler at the break, with every passing hour, I think my imposter syndrome only grows. So I should give some caveats. For starters, I'm a clinician researcher, and I also work in a policy unit in Washington, D.C., the Center for Professionalism and Value in Healthcare, where I'm a co-director, where I had as a senior vice president for research and policy for the certifying board of the second largest specialty discipline in the United States, family medicine. We're going to talk a bit about that today too. And I manage a number of leadership and scholarship training programs and still practice in a residency that's just outside of the district and affiliated with Virginia Commonwealth University. None of those things really qualify me to do much more than spell words like artificial intelligence and machine learning, but I am here to present problems and look for your help with the solutions. And also, as Dr. Fackler noted, just to point out a few things about primary care, and specifically, hopefully some things that aren't fully appreciated by all in the room. I want to go through a little bit of background. I came into medicine instead of a career in the State Department, the CIA, the Peace Corps, as I was pondering in my liberal arts undergrad education for quite some time through work in rural Bolivia, where primary health care, as I came to understand it, didn't stop, as it often does in outpatient-only clinics with 15-minute face-to-face visits. It was an extension of public health, population health, direct interaction, and working across whole sectors that included frontline community health workers, actually data scientists on the ground, even in Bolivia, doing a better job of collecting community data than I've found in my own practice at home. And our own Institute of Medicine, now National Academies of Medicine, has said, if you really want to define what we mean by primary care, this is not, as it's sometimes labeled, basic medicine. This is essential, fundamental care. It's providing integrated, accessible healthcare services. And the clinicians who do it are supposed to be accountable for addressing most of what their patients and those families and the populations need. It's supposed to be about a partnership and about practicing in a broader context within that family and community. And actually in Dr. Fackler's home institution, a well-known to the primary care world, health services researcher, Barbara Starfield, spent 25 years revealing that powerful health systems around the world who spent less to achieve more, really built around that essential notion of primary healthcare at their base. The US has been very technologically driven and very driven by its subspecialty sciences and hospital medicine, perhaps a little less so around primary care, but regardless, you're talking about the largest, the most widely distributed platform of healthcare delivery in the United States. For the data scientists, you're talking about information that comes out of 500 million plus visits per year. That's over half of all encounters just in healthcare and in medicine. You're talking about 70+% of the encounters for the 14 high-cost conditions that Medicare has ranked, or the 15 priority conditions that the Agency for Healthcare Research and Quality has ranked as priorities in our health system. Be they, again, acute MI, osteoporosis, asthma, and others. Despite all of those numbers, it remains woefully underfunded, 5 to 7 cents on the dollar in US healthcare spending, pretty overwhelmed, perpetually challenged with staff burdens. And that's not just the physicians, that's the entire team that's trying to deliver it, and certainly on the front lines in the community. And having a difficult time achieving what Barbara Starfield labeled the 4 key functions that make primary health care salutary, positive for health effects. She said that's primary health care that delivers first contact, coordinated, continuous, and comprehensive care, all of which, if she were alive today, she passed in 2011, she would say are potentially enhanced by the power of artificial intelligence and machine learning. And so we've seen AI and ML revolutionize all sorts of industries. This conference is evidence of its penetration in medicine, but it really is far from penetrating, much less transforming primary care. We did a review with Jackie Cooper out of Toronto, Primary Care and AI, and it really concluded that it's pretty obvious from the absence of the DARPA literature that this field's in the earliest stages of maturity, despite in primary care, that is, despite a 35-year plus history, and only 1 out of 7 papers that we could find looking at primary care, AI, and ML, tellingly, actually had a primary care clinician author. So you're infrequently seeing this integration of the end user in the design process, and this is nothing new in primary care. The same has happened with electronic health records. I would say as the genomics revolution starts to hit the healthcare system, that largest segment is scarcely aware of what to do with the information it's processing. So it's not that big of a surprise that, again, machine learning techniques and artificial intelligence have yet to penetrate. I would say that for this group, for the data scientists, you scarcely tap the power and the depth and the breadth of the data and technology that can come out of and then be returned to primary care practices. I think we've also failed to start with a design theory that looks at what the nation's goals are for health. And we started with Don Berwick labeling the triple aim. We then added, as we noticed, that clinician wellness was a major problem, which we'll get to a little later. There's a quadruple aim. And then of recently, in the context of George Floyd's murder and a national conversation about equity, added equity and outcomes to make this a quintuple aim, where we're aiming for better health, better patient experience, lower cost, improved clinician well-being, and equity in our outcomes. And as we start to look at the algorithms that could emerge from artificial intelligence and machine learning to improve this largest platform, primary care, it's with these end goals in mind. We set out, and I already confessed, I'm fairly new on this journey. My research has not touched this space much, if at all, and I'm more of a learner and a voyeur, but did want to get our board rallying with its power across the community of family medicine departments and primary care. Again, this underattended to clinician and research group to pay attention to what we need to do for setting research agendas for artificial intelligence and machine learning in primary care. So we held a meeting, had the pleasure of Mark attending with 30 or 40, we thought really leading thinkers in the space to teach us a bit more about, well, what should we be doing as we put our funding and our time and our energies into linking up the primary care engine with the tools and transformational technology of artificial intelligence and machine learning. This is an impossibly busy slide. I can share the paper if you'd like to read in more detail what came out of that meeting, but I'll just tell you that we boiled it down, as you know, clinician researchers tend to do, into a mnemonic we called ideas, where we said absolutely the opportunity starts with infrastructure upgrades. There has to be some form of multidisciplinary and multiple data sourced longitudinal research data platform. We're not capturing and using the primary care data effectively. Even the large integrated health systems have locked down so much of their proprietary data. We need to get real primary care data if we're going to have less biased and more patient-centered algorithms emerging. We have to transform delivery, and that really also means training, so that we're speaking the vernacular. I can scarcely do it myself, and I'm standing in a room with experts. You can only imagine with this massive workforce in primary care how far we are from really understanding what we can achieve with AI and ML. We've got to change and modernize evaluation. The way we do health risk assessment in primary care is woefully lacking. We have to, again, improve our algorithms and get contributions from patients and primary care clinicians. We're in an era where trust is lacking in our encounters with our patients and our populations, and we have to incorporate ideas of social justice. We are on the front lines dealing with what happens when trust breaks down, and it leads to vaccination crises or the absence of vaccinations in a COVID epidemic. It leads to the wrong medicines landing in the wrong places, and frankly, the absence of right medicines in the right places. And again, we have to link this to achieve greater efficiency, effectiveness, and equity in that quintuple aim. One of our partners in the process, a family physician working out of Stanford University, Steve Lin, his partner, Chris Sensky, at the American Medical Association, put out a nice piece in the last 2 years where they tried to boil down 10 ways that artificial intelligence can transform primary care and achieve the same. And again, I'm sorry for the busy slide. Hope you'll see that these are supposed to be circles that reflect on some components of the aim. And if you want, again, more information, I will steer you to the article gladly. But what Steve and Christine really did was say, all right, let's just look at the market capacity and projections over the next 5 to 10 years for this massive sector of primary care and break down some of the possibilities that a good data science clinician dyad could take on and what it means in terms of market cap. For example, they could tell you, if you look at just that risk prediction and intervention level for the payers and the employers, with better risk, again, prediction for what I can make of the many, many phenotypes that walk in my office. In a primary care setting, they don't wear one disease and come for one problem. In a typical visit, I may code 7 things, and they may range from the well visit that the person nominally came in for, to the UTI they developed in the last week, to the 15 questions they have about vaccine safety, to the 5 chronic diseases that I'm taking care of part and parcel, some with a specialist partner, some without. And I've got to figure out how to make some sense of that unique phenotype in a broader context. And I can't do it with what regression techniques and disease-specific reductionist models have given me so far. There is a $100 million opportunity, say Lynn and Sensky, to modernize risk prevention and intervention just based on the companies that are getting in the game already. When you go up a bit, I'm looking at the other big circles. Chart review and documentation. If we're going to overcome the multi-billion-dollar effects of burnout, where we're losing clinicians and team members, I have turnover in my practice on a near monthly basis for the medical assistants that are really the lifeblood of keeping my team and my day-to-day practice running. We've got to get better and more streamlined in how we extract things from the chart and put them back in the chart. I really enjoyed a conversation last night that gives me hope. I keep hearing about digital scribes coming into the room with me, translating all the information in that 7-part encounter into something that is interpretable and meaningful to me and all my teammates. And again, Lynn would say there's $100 million, 100 million reasons if you're in the market space to get into the chart review and documentation space. Simple things, this device integration. It's great that my patients all come in with their iWatches and they want me to look at mountains of information about their 2-lead EKG. It is not interpretable at the moment. And even with Apple's attempts to do some integrating that can push simple feeds straight into my EHR, we have a long way to go to take advantage of the radical transformation that biometrics and devices offer us in primary care and can help us in sparing downstream costs for ER visits, hospitalizations, unnecessary trip to specialists. And I could go on and on. Digital health coaching, I'm blown away to see move to sell for $100 million to 12 Asian countries, a huge digital coaching enterprise that I haven't even seen come into my practice. I would do so much if I had access to diabetes management coaching. That's $1 in $7 in US healthcare. Keeping my diabetic patients' A1Cs under control, it's a perpetual challenge. If I had help beyond the very limited extension teams that I can find in the community, nutritionists, coaches, et cetera, from digital health coaching, I could do a far better job in the future of managing their diabetes without needing endocrinology help for so many things and without them going to the hospital quite so often. So we're trying with, again, we're simply a certifying board that happens to have an expansive vision of its role in the primary care community and working with other certifying boards in primary care. But we are trying to build out over the last 6 to 7 years a unique data repository, Prime Registry, a place where you can get some of the smaller solo and rural and urban practices that you don't see in these proprietary large integrated data sets, trying to help build out synthetic data sources for the Agency for Healthcare Research and Quality that other primary care clinician dyadic teams with technologists could use to build out primary care specific algorithms. Convenings like the one I mentioned, trying to get out into communities like these and present and share what we think are problems that you could help us solve. And of course, building out human capital. We've specifically been this winter and spring working to get out calls for proposals where we can bring in, again, real resources into departments, not huge, certainly not at the NIH level, but resources that could help them get on the first rung on the ladder to do more research built from the patient to clinician idea and entering use of AI and ML to solve real primary care problems. We know that we're going to only fund groups that are willing to take those kind of steps of iterative design that actually integrate patients and integrate real clinicians, not just the researchers. And again, we've put out these awards for 5 years where we're asking departments that are successful in working with us to embed at least one AI/ML researcher in their typically small family medicine departments, fairly modestly go for at least 2 externally funded research proposals by the end of their time, using $100,000 per year pilot study cycles, and produce at least 3 peer-reviewed publications. And it's producing partners such as Winston Liao. Winston comes with a background as the chair of population health. He is a family physician at a newly created University of Houston, which requires all of its med students as they come through, not to think in terms of organ systems and bodies alone, but to embed in their communities, have an adopted family that they go through their 4 years with and learn from, and really take a different approach to how they process new information in the first 4 years of their medical training. And so in his approach, he wants to build out primary care forecast, start with diabetes risk prediction as his problem to begin solving, and specifically partner with University of Texas and University of Houston informaticists to take diabetes risk prediction models and update them in the primary care setting so that he can start to explore what are the different phenotypes of diabetes that the primary care clinician typically experiences, and how can we, again, using this idea of risk prediction and forecasting, better adapt and specify the medications we use, the nutrition and diet counseling, the exercise prescriptions, et cetera, for a particular phenotype of diabetics. Ioannis Kakiadaris is his dyadic partner coming from the informatics group and the data science group at Houston, and he has a number of others that he's bringing along as well. In Pittsburgh, UPMC is actually the largest family medicine unit in the country. That's a UPMC, for those who know it. I see many from Carnegie Mellon in the audience. Is far more than a health system. That's a group that's investing in venture capital and data science well beyond its hospital primary care clinics. But Tracy Conti, the head of their primary care department, and John Mayer, who is their lead investigator and research director, have decided they want to build out informatics to better understand patients as patients, not just diseases, and specifically have used an approach that will begin to pull UPMC and other data and try to help a family physician or a primary care clinician on the front line who's seeing a patient. Imagine that somewhere out there in that 500 million visits across many, many years, there is another series of patients that are similar in phenotype, and try to build out patient, again, phenotyping to begin to understand the specific diseases that they face. In San Diego, Rusty Collenberg and his team, within the largest research unit in family medicine, and working together with informaticists and research partners, are specifically taking on efforts to take the UCSD primary care data enterprise and our own prime registry and tackle multimorbidity. They want to build out a mechanism for clinician-fed ideas to go straight into their AI and ML pipeline. And I'll just give one more example. Carlos Hayan, who's at the University of Texas, San Antonio. His department has been at the forefront of applying complexity science in primary care for many years. The idea of modeling and better understanding the seemingly abstract patterns of bird flight, having been at the nidus of that science. And what Carlos and his team want to do with their Texas San Antonio group, and again with informaticists in their unit, is to tackle, again, not single diseases, but multimorbid problems in their phenotyping. So they're going to be building out predictive models to understand diabetes and hypertension first, and where they might best apply specific phenotypes to shaping pharmaceutical therapies. But their long-term goal is to create algorithms that are not single disease specific, but help them to understand the multimorbidity that we see in primary care. I think Steve, our partner at Stanford, as I move towards the end, is teaching us that we need also to draw together a cohort of these dyads, but specifically get those who are capable and ready to begin thinking about how we apply artificial intelligence and machine learning in the primary care setting together. Steve's going to be helping to create a multi-year cohort of investigators that will be looking around for data scientists to partner with. And as he said here, I believe that primary care is the dominant force at the base of the pyramid with an unrivaled interconnectedness to every part of the health system. And really, especially it's built around these deep relationships with patients' communities, is perhaps the most uniquely suited specialty to lead health and AI revolutions. And ironically, the one that is least involved currently. The cohort's going to get together on a periodic basis. We already have our first face-to-face meetings planned at the North American Primary Care Research Group annual meeting in Phoenix in the fall. And again, try to build on each other's innovations and learnings, try to align and to act better together, and also to find other data partners and other data scientists to work with. The opportunity is very real, and I would end with the notion that this is that opportunity moment for primary care to serve those foundational functions that achieve the nation's quadruple aim. It's also the moment at which we've watched previous revolutions leave us on the table, but not at the table. Served up algorithms that are neither interpretable or necessarily fully useful for our community, rather than being involved in that design process and in building it out. It's going to take considerably more capital, financial, human, and digital, than we currently have invested, and a lot of attention from much bigger partners. I'm eager to see, with the Amazon purchase in the last month, or the announced purchase of One Medical, one of the, as they call them, advanced primary care models, which also purchased Iora Health, another advanced primary care model, a few years ago. I'm eager to see what they will be doing as leaders in this space. These are offices that are bucking the notion that you can sit in a box in those 15-minute visits and achieve a heck of a lot if that's your vision of primary care. And they absolutely are visionary in imagining technology paired with that human capital being the way forward. I think we can see a future, however, where we can effectively integrate AI, facilitate these features that I've talked about. And that's the only way we're going to get to achieve the quintuple aim. And I'll look forward to questions after hearing the next presentation. Thank you.
Thank you very much. The good news is I think we've got 3 or 4 hours at the end to go through all the questions that I've got. Let me next introduce